Hello everyone, this is Jonathan Sarhadi from MCOL, and I would like to welcome you to our webinar event today, Persona-Based Population Strategy, Incorporating Predictive Modeling into Member Care. Our speakers today are Bob Gladden, VP, Center for Analytics, CareSource, and Cathy Meade, Director for Healthcare Analytics, CareSource. Before we begin, we do have a few housekeeping items to cover. If for any reason you experience technical difficulties with the web portion of today's presentation, please print off the PDF version of the presentation that was included with your dial-in instructions. The link is www.healthwebsummit.com/predictive031815.pdf. Our speakers will be taking questions today using the live chat feature. So, now and at any time throughout today's webinar, you're welcome to submit your questions. As always, if you require any other assistance, please contact the Healthcare Web Summit office at 209-577-4888. We are now ready for our speakers to begin.
Good afternoon, everyone. This is Bob Gladden. I wanted to start off this morning by giving everyone a little bit of detail about CareSource itself. This will be important as we actually walk through the persona model. Largely because as we walk through the persona model, there will be some data components that may not necessarily make sense unless you understand the foundation of the organization that actually has the data that went into the model. So we're actually going to begin by spending a little bit of time talking about who is CareSource. So this is not, CareSource has nothing to sell. We're actually, as an organization, a nonprofit organization that is largely in the Medicaid space, and this gives you a few facts about us as an organization. So we, again, are largely in the Medicaid space, mostly in the state of Ohio. We have around 1.25 million members in just the state of Ohio. That's CFC, which is Ohio's term for TANF. If you are working in other states, that may make more sense to you, but Ohio gave it its own name. ABD, or the age blind and disabled population, and then expansion. Ohio actually entered into the expansion component of Medicaid last year, which actually has grown significantly over the last 12 to 14 or so months. CareSource actually has some members now in a waiver program. We actually just exited the SNP population recently, so even though these slides were sent a couple months ago, I do have a couple of updates. So we have around 1,800 members in a waiver program. We have around about 25,000, in a MyCare program. Ohio is part of a federal duals demonstration project that's Medicare and Medicaid together. And that project, we are actually in the northeast section of Ohio, where we are working with both the feds and the state on that project together. We are in an alliance with Humana in the state of Kentucky, where we have the TANF, ABD, and expansion population. That membership actually now is around 111,000 members, and we are continuing to be involved in Kentucky in that membership. And then our Just For Me product, which is actually, we're on the exchange. We actually entered onto the exchange last year, and we began the exchange in just the state of Ohio. We expanded the exchange this year into the states of Kentucky and Indiana. Now, as everybody who's worked on the exchange knows, there's lots of different ways you can measure the exchange. The measure that we're using is paid membership, and those numbers have changed quite a bit since I put these slides together as well. We're now at 70,500 on the exchange. Our experience last year was pretty solid in the exchange. We focus our efforts primarily on those that are heavily subsidized. That continues to be our focus. The bulk of that membership is Ohio. However, we've grown significantly to over 20,000 in the state of Indiana, and then the remainder of that is in the state of Kentucky. So that's a little of the flavor of us as an organization. All of our data is centered obviously on that population. Obviously the majority of it is on the Medicaid population in the state of Ohio. CareSource has been in business for 26 years. So because of that, we have obviously a very rich database, and that allows us to do some things that other organizations probably don't necessarily have the luck of being able to do. So we actually have the ability of going back a number of years and trying new things and then testing them out in the data to find out different methods and different formulas and trying to understand what happens over time if we try different things and actually watch them play out in the data. And then when we actually put them in place, we have a pretty good feel for what will happen when things are actually put in place live because we've already tested it with the data into the past. A couple of other things about us that are somewhat important because it does play out here as well. We are a nonprofit organization. We are very mission driven. We're one of the few organizations that you can go all the way down into the mailroom and you will find people who can largely quote what the mission of the organization is. We are very driven by a low administrative expense. We run around a 6% administrative expense that is significantly lower than virtually any other organization that does the same thing we do. Most organizations are running in the 9 to upwards of 15, 16% range. So that is both a blessing and, as you can imagine, at times a bit of a challenge. However, we also, as an organization, have had a dedicated analytics focus for a number of years. At this particular time, we have an analytics team of around 25 that includes myself, a director, and as well as a couple of managers, and then a team of analysts that are spread out amongst a number of different functions, including informatics. We have some predictive analysts that actually are heavily into statistics, healthcare analytics, as well as a team that works on research and outcomes. So again, as an organization, we've been in business around 26 years, pretty much heavily in the state of Ohio. We have a variety of arrangements in place with a number of providers in the state that range anywhere from typical fee-for-service to some arrangements in place with some fairly advanced provider organizations that are basically ACO-like. And in fact, with one organization, we have something that's like an ACO that has been in place for really a number of years, and they're actually further out ahead than most organizations that are trying to put ACOs together today. So we have a variety of those kind of relationships that have been in place, and some of them are in fact working very well and have some pretty solid outcomes. And all of that is in the data that then goes into some of what you're about to see. So the starting point that I'm going to actually introduce is sort of how we got to the need to put personas together, because that's sort of history and foundation I think is critical. I'll then hand this over to Cathy, who's my colleague, who will then spend some time actually discussing personas and giving you a little flavor of how we constructed them and carrying forward how we're physically using them. But the starting point really became us as an organization trying to deal with, I think what a lot of organizations are doing, and trying to work through this question of the dilemma of identifying members based on disease and or high cost. So we as an organization were trying to continue to work through this issue of disease management, trying to identify programs based on costs. We have a model that looked probably similar to what a lot of folks have, which is we had members, we had various numbers of programs, and we had an attempt to take members, identify what programs they belonged in, and then we would attempt to slot them in these individual programs. Some of these programs were CareSource programs. Some of these programs were state-mandated programs, and some programs were some combination in between. The challenge this created was that many times what we would have is a member who would be slotted in multiple programs, but they didn't necessarily communicate well with each other amongst the different programs. So we as an organization actually became somewhat guilty of the same thing that has happened some in the field of medicine, which is as opposed to taking the body and breaking it into different parts and having different specialists looking at different parts of the body without necessarily considering the whole, we were doing somewhat of the same thing with our members in terms of breaking them into different programs and not taking into account the fact that we may be contacting the same member multiple times. Those multiple connections were causing some fatigue in terms of us trying to contact the member, sometimes the same member, sometimes the same household, about different programs, and we were getting a lot of inefficiencies because we were not having good connection points. We also at the same time were trying to identify a number of things about cost of members, and there were a variety of things that were happening because of that were causing that to happen. Much of it was driven by a HotSpotter article that happened to be published in the New Yorker about, I'm thinking about 3 or 4 years ago, and we'll get back to that in a moment, that drove a change to how Ohio required some things of the managed care organizations. and some new requirements that came up on the managed care organizations in the state of Ohio in terms of how we were to manage what was to be identified as high-risk case management or high-risk members. So we went about attempting to identify who are our high-cost members. Seemed like a fairly straightforward task. So we went out, and again, this is where it's important to understand who we are and our business. We went out and identified who were our high-cost members. So we went out and found what are our primary disease drivers. Now, I left off of this pregnancy because we're not attempting to identify that obviously as a disease. So we left pregnancy off of here, but without pregnancy, again, considering this is primarily Medicaid, so you're not going to see some diseases that you certainly would expect to see if we threw, for example, Medicare in the mix. This is a Medicaid population. So as a Medicaid population, these 7 diseases represent a very large percentage of our overall expenses. So not surprising that you would see diabetes, hypertension, depression, low back pain, asthma, ADD, and obesity. We then went down the path of trying to identify exactly what is the cost associated with a diabetic member. Not surprising, what we found out pretty quickly is that it's very difficult to actually identify the cost of a diabetic member because there's so many other things happening with a member who has diabetes. And what you see on this chart is we actually went to the level of trying to say, okay, so for a member who is diabetic, what's the likelihood of them having comorbids? So in this particular case, you'll see on the chart that diabetic, where it says diabetes is 89%, it's saying that 89% of diabetics have another disease, or they have 89% of them have a comorbid. In fact, around 80% of them actually have more than 2 diseases. And in fact, the numbers are something in the neighborhood of 70% of them have more than 3 diseases. Again, not terribly surprising, but when you're trying to isolate the cost of a diabetic, it becomes difficult quickly because it's not abnormal for a diabetic to also be hypertensive, potentially also be depressed or obese, and may in fact be depressed and may in fact not be on their medication appropriately. Well, if that in fact is true, then if I'm having a diabetic campaign to attempt to have a conversation with a member about, for example, their diet, having an interaction with that member about their diet when they're in fact a diabetic who's hypertensive, depressed, obese, and they're off their medication is probably not a very good interaction with the member when I in fact should be having a very different conversation with the member. So we had these siloed programs that became created that weren't necessarily having good interactions with our members. So it caused us to really step back and rethink the way we were looking at our members internally and say we've got to stop dividing them up by diseases and start thinking about our members as total individuals, and that's really where the persona methodology started coming into play. Now, another factor involved in this was also a conversation that we were having with the state of Ohio at the time, where again, as I was referencing the New Yorker article on the hotspotters, where that article was making a high reference to the fact that the majority or a high percentage of cost of care is being driven by 1% of our membership. So 1% of members drive a high percentage of cost of care. And in fact, everybody's heard the 80-20 rule where 20% of your members drive about 80% of your cost. That in fact is largely true. Equally true is about 5% of your members drive around neighborhoodish 50% of your cost, and in fact 1% of your members can drive upwards of 25 to 30% of your cost depending on your health plan and the kinds of expenses that you have. So that hotspotter article was very heavily driven towards do everything you can to manage that 1% and you'll get your costs under control. So we ended up with a process where we were asked in our contract to manage folks, and they were identified originally as individuals that were in the top 5% of cost, being that that was the target. We were supposed to go out and find people who had been in the top 5% of cost, and that was going to be our focal point, and those are the folks we were to identify and try to get into high-risk case management. After a fair amount of time and going back and doing some looking, what we quickly identified is that that's not necessarily a good measure. Again, thinking about our population, we pretty quickly were able to identify that in fact Identifying who's in the top 5% of cost is not a particularly good predictor of who's going to be in the top 5% of cost next year. In fact, what we were able to find is that the false positives ended up being 54%. In other words, if I look at last year's cost and I take my top 5%, 54% of them will not be in my top 5% next year. Now, there's a variety of reasons why that happens, and as you can imagine, we've taken that group apart and tried to look at and identify why it's occurring, but it becomes a pretty poor predictor of future costs. So past cost is not a good predictor of future cost. And in fact, we were spending a lot of energy looking at folks that honestly, and our care management team does not probably appreciate this, but honestly, if we do absolutely nothing, 54% of them will end up not being in high cost next year, which sort of makes it look like the program's successful, except they're not going to be in high cost anyway. So it really caused us to have to rethink the way we put the program together, which led us down a path of saying it's time to really start creating an entire transformation around how we do care management. Move away from the siloed programs, moved away from the single disease-based programs, and rethink this. Take some pages out of the way retail does business and do this differently. Again, if we think about this at a high level, we started looking at the problems with the old approach, and we were looking at the interaction fatigue that's created by those siloed programs, that we know we have some issues. We know we have inpatient stays that are happening, or we're trying to connect with members with inpatient stays, and we have disease diagnosis patients that we're trying to connect with, and high-risk patients, and we have ER programs. The problem is those programs are getting identified. Sometimes before we actually get to the member, they're already crossing through what we would call that threshold of impactability. By the time they actually become identified, they've already passed over the point at which our ability to really impact the member has occurred. Therefore, the expense has already occurred. By the time we actually interact with the member, it's already after the fact. Again, we need to figure out a way to get further up the road so we have the ability to actually have an impact on the member before the event is occurring, understand what's happening with the member before the event is occurring, and stop trying to simply address them based on the fact that they happen to be in a program that's disease management, therefore this is the month to have a conversation about whatever the program was for that disease management, which caused us to say we need a new approach. It's time to do this differently. It's time to take some pages out of some other industries. And analytics is quickly moving fast in other industries, and we knew it was time to take a page out of some of the way other industries do business and take those approaches and start applying it into the healthcare arena. So I'm going to pass the baton over to Cathy Meade, who is the Director for Healthcare Analytics at CareSource, and she's going to start walking through what the next steps were and how we went about this next.
Thanks, Bob. So what we did is we actually performed a cluster analysis in order to segment our population based on their clinical needs. So, and I went to the wrong slide. Just give me 1 second here. Sorry about that. Okay, so this slide here is a depiction of the cluster segments at a high level. Obviously, I'll be walking through these in a lot more detail with you, but there are 9 of them, and as you can see from the large purple segment, the vast majority of them are there, and that is actually a group that represents our healthy kids. So this slide is a high-level depiction of the actual process that we went through. So we have a lot of different data, as many of you are aware, in the healthcare industry. We took that disparate data and we pushed it through a process, really performed a cluster analysis. And what we were left with was individual segments of our population, and there happen to be 9 of them. We refer to them as our clinical personas, and I will continue walking through those so you can get a feel for them in more detail. So this next slide talks a little bit about the inputs that went into the cluster analysis. So half, which is 6, there were 12 in total, 6 of the inputs are actually coming from the outputs of data that's available from our Johns Hopkins ACG software. So we utilize the the Hopkins software, and we've taken 6 of those predictive components out of that software and combined that with 6 historical data elements, and those actually represent inputs into the model. The next slide is our outputs to the model. So again, there's 9 clinical personas here, and I'm going to walk through those with you. But what was important is for us to really look at this holistically for the organization and not just have this be something that the care management team does and it doesn't fit into what the rest of the company is doing. So what we did was we worked with our marketing and consumer experience teams to really roll these up. So at a high level in the organization, we had a view of our population. So from the highest level, we group this into 3, and it's our well group, our acute episodic group, and chronic complex, which is your traditional care management focus. So the well acute group represents about 80% of our population. The acute episodic is about 15%, and then the remaining 5% in the chronic complex. So if we dive into that well acute group a little bit, we have healthy kids, healthy adults, and acute kids and adults. And so, the first 2 are obvious. The distinction is kids versus adults. What makes the third group unique is that these folks actually would have fallen into one of the other groups, with the exception of their high ER utilization. And I'm going to talk about why that is in some upcoming slides. But that ER was significant enough that we actually decided to break them out into another segment, because what we might do with them in terms of intervention might be a little bit different. The acute episodic, these are somewhat unique. All of these kind of go across the continuum of care, but the acute episodic group has a little bit of uniqueness to each of the segments. Group 4 is primarily high-cost drugs. So we have high-cost drugs, and a good portion of that actually is kids with ADD. In Group 5, this is predominantly severe mental illness, substance abuse, and some other at-risk conditions such as that. This we have mental illness that spans across other groups as well, but when they are in this group, that's predominantly the only thing they have going on. So they don't have all those other chronic conditions complicating their mental illness. Group 6 is uncoordinated care, and again, I'm going to go into this one in a bit of detail as well, because this is a unique group. What we really found out about this group is they're a group of people where their care is simply uncoordinated. They are having a lot of things done. It's very disparate all over the place, and our focus for these individuals was really to get their care coordinated. And then the last 3 are, like I said, the traditional focus for care management. There are some nuances. Group 7, chronic coordinated, they're managed more through medications. The complex managed in Group 8 is managed more through outpatient visits. And then the extreme complex is those folks that have, the high hospitalization, largely bedridden and things of that nature.
So we do have one question that I saw that came online, so I'm actually going to back up just one slide for a moment. And it's asking about the specific clustering algorithm that was used. For good or bad, you don't really have the statisticians sitting in the room right now. What I can tell you, it was a k-means clustering methodology that was used. And these 12, and it just happened to work out to be 6 and 6 variables, were what was used to feed into that. We actually started out with considerably more inputs. These were the 6 that tested out to be the most accurate and the most through a series of methods, and I'm not sure exactly what all the process they went through to actually pick this 6. But the 6 that came from the ACG system, some of these actually are predictive methodologies that are actually coming out of the Johns Hopkins software system, and I will walk through those just real quickly for a moment so you know a little more detail about what those are. So the medical high cost probability is actually a predictor of future high cost that's coming out of the ACG system based on past claims data, and it's not really so much the cost as much as it is driven by the actual diagnostic experience of the member. The problem is the high cost probability is going to be the same thing. It's going to be based on the previous claims data of the member. The active ingredient count is a count process the ACG system uses to actually count active ingredients that a member is using. So it's not actually counting number of fills or something like that. It's actually counting active ingredients. The chronic condition count is actually, again, counting number of chronic conditions, again, as defined within the Johns Hopkins software system. Hospital dominant count is a predictor of future hospitalizations, again, based on the diagnostic information available for that member. And then major ADG count is major ADG is actually a representation, again, defined within the Hopkins software system of major diseases that it tracks, and so that's a count that's actually happening within inside of that software product. The other 6 are probably more self-explanatory in terms of just those are data that are coming out of the enterprise data warehouse. So it's probably not maybe as many specifics as you're looking for, and obviously some of this is going to be proprietary in terms of what we have retained internally. But then the k-means clustering was the actual cluster analysis methodology that was used from there. Sorry, Cathy, didn't mean to jump on top of you, but I wanted to answer that question while we were there.
Okay, so moving into more, a little bit more detail of these individual personas, I'm just going to highlight some things along the way. So if we look again at the 3 healthy ones, again, that represents 80% of our population. Then we move to, let's look over at the bottom right in our extreme complex. You can see that the inpatient visits per 1,000 are significantly higher for that group versus all of the other groups. If you look at the bottom, the light blue bar on the 3rd group, we can look, I mentioned that that group has higher ER than their healthy counterparts. It's actually 8 times higher than their healthy counterparts. So that might help explain why it was important for us to pull this out as a separate group, because obviously with ER per 1,000 that's 8 times higher than their healthy counterparts, we're obviously going to want to do something different with that than what we do with our general healthy population. So the last, if we look in the middle at uncoordinated care, group 6, this is just a really, again, a really unique group, overdiagnosed, undertreated, and they have lots and lots of conditions, but not necessarily a lot of chronic conditions formally being diagnosed. So 2 or fewer chronic conditions on average, but the actual number of unique diagnoses that they have is, upwards of 24, 25. So just a lot of opportunity there to coordinate their care. And as Bob was talking about earlier with the top 5% of the costs in those, false positives, this group is unique. This is actually a group that we identified that is going to be in our future top 5% of costs, but isn't today. So when we really, all of us want to get in front of the cost as much as possible, this is a group that really allows us to do that. Okay, so next, this is actually, again, same groups, but showing how disease prevalence is spread across these groups. And really, this is only one example. We have taken a lot of different types of data and cross-cut them with their personas to really bring a lot of things to light. That's really been eye-opening for us as we've gone through this. So disease prevalence is just one of those, and I'm going to show you here. So again, if we take that diabetic person that Bob mentioned and we look at them across the personas, we can see how that falls along the care continuum. So obviously you have some diabetics who are in the healthy space, a lot fewer of them. Those are probably the ones where it makes sense to have a diet conversation with them. And then when we have the diabetics who have lots of other comorbidities, we want to tailor interventions for those folks differently that are really more appropriate for what they need. So not necessarily just that conversation about their diet, but really a more holistic approach to dealing with that particular patient. So again, talking about the top 5% of costs and those false positives that were previously 54%, we actually redid that using the identification of the persona, the clinical personas, and we were able to reduce the false positives down to 32%. So clearly there's still more work that we're doing here at CareSource to improve upon that 32%. But without a whole lot of effort, you know, taking the false positives from 54% to 32%, we're pretty happy about that. So next I want to show you some ways that we're actually using these personas in the care management space. So somewhat of a journey map here. If we look at this particular individual, they are a pregnant person in persona 2, which is a healthy adult. This particular individual has a prior history of preterm labor with gestational diabetes. And we can see that in the first event here, they're going to their OB visit, and they have a positive pregnancy test at 12 weeks. And so overall, the gray areas represent the events, and where we've layered over the red is the opportunity for intervention. So if you think of this maybe a before clinical personas and after, you know, the picture of this same slide without the red, what we would have done and now what we're able to do because of this work. So as we take this pregnant person with a history of preterm labor and gestational diabetes, we see that they had an OB visit for that positive pregnancy test, and then we're able to identify through, again, our use of the ACG tool, which allows us to identify the high-risk pregnancy. We're able to trigger an event to our care management staff to say, hey, this person you know, came in and they were pregnant and they actually have a history of gestational diabetes, preterm labor, and they're also triggering as high-risk pregnancies through ACG software, so we want to actually tag them and alert our care management staff to do something with them. So if we, again, go to the gray, what we would have done previously is we would have had that, you know, OB visit, you know, potentially some follow-up prenatal visits, and wanted the person to be put on bed rest and ideally get to that full-term delivery. That's what we can do with the triggering event of that high risk. What we would have had if we did not trigger that high risk is most likely a preterm delivery, not at 38 weeks. And I think I said that backwards, so my apology if I confused that a little bit. So this next example, again, another pregnant individual, this one out of Persona 6, that uncoordinated care group. This woman is a 32-year-old female. She has obesity, low back pain. She's a smoker, and she also has a sexually transmitted disease. She is going to visit. She went to an outpatient visit for low back pain, an urgent care visit for musculoskeletal pain. While she was doing that, she was receiving opiates, so we can see that in the system. And then in the next event, she was actually going to the ER for bleeding and low back pain. While she was at the ER, they discovered that they did a pregnancy test and discovered that she was pregnant. She was unaware of her pregnancy. And so that's another opportunity for a triggering event to say, hey, there's that positive pregnancy test there, and we have this history of opiate use. Let's go ahead and alert our care management team of this activity, because obviously we want to get her off of opiates, manage her pain throughout her pregnancy, get her off of opiates during the pregnancy, and ideally post-pregnancy as well. In this next example, we have a member from Persona 5, which again is that mental health, roughly the mental health persona without a lot of the chronic complications. And so we have someone here who is a 44-year-old male with bipolar disorder. And in the first event, we see here that he has a visit with his community mental health center. So he does have a relationship, and he is actually receiving medication, and we can see that he has 2 medication fills after that. And then what we see is a gap and an ER visit and a follow-up with the community mental health center. What we are able to do now is take that individual, have a triggering event on the medication gap in an attempt to, to really avoid that unnecessary ER visit. So the next few slides, I want to just kind of walk through with you some things that we're working on now and where we plan to take this in the future. So this slide is really showing an example, just one example of movement over time, because while we did a cluster analysis and segmented our population into the 9 clinical personas, that doesn't mean that they stay there. In fact, they don't stay there. They actually move quite a bit. And so this solution that we have needs to be very dynamic and manage folks for, the condition that is actually primary in their life right now, and focus on that. So if we take that uncoordinated care individual in the center here, and this is looking at year over year, all of the breakouts in the movement visually shows you where those uncoordinated care members went in the following year. So we have, some of the uncoordinated care was due to pregnancy complications, and so post-delivery, that female reverted back to a healthy clinical persona. We have another one who they were potentially, it's that, overdiagnosed and undertreated. Maybe they did not actually get tagged with a chronic disease that they had. So through care coordination, we were able to get them the proper diagnosis for the disease that they had and get them, the care that they needed. And then they're actually, working with physician, proper care coordination, and being able to control their disease. So they might move into a little bit of a sicker persona, but their disease is actually being controlled, and that's a good thing. And so we have a few examples of that. And then we also have part of those folks who remain uncoordinated, unfortunately, and then they go on to be sicker and not controlled into perhaps persona 9. And in that particular example, we had conditions worsening because of cardiac smoking complications and cardiac events. So this next slide just gives you some ideas of additional opportunities. We have many, many more than these, just tried to highlight some of the high-level ones here. So when we look at, again, kind of triggering events and alerts into our care management staff and tailored interventions based on, the unique scenarios that these members are facing, we look at persona 2 healthy adults. And one of the things we want to know there is, do they have a relationship with their PCP or not? It's very basic, but a lot of times, we don't think to go after that because we're only focusing on the complex population. Again, persona 3, I mentioned the ER. Was that ER avoidable or not? And what we know at CareSource through further digging, we actually did some root cause analysis, and we found an opportunity here with a group of kids who have a diagnosis of asthma, and their asthma is not being properly controlled. So that was a really good opportunity, and it helped us explain why we had these unnecessary ER visits. So, in terms of tailored interventions, the thing we want to do there is work with those individuals and their physicians and really attempt to get that asthma controlled so we can head off those future ER visits. In looking at persona 5, our predominantly severe mental illness and substance use, what we want to understand again is, do we have compliance with medications? You know, a lot of this in Persona 5 is we don't want them to revert back to a healthier persona in this particular case, because if they do, we know that it probably means they're doing that just strictly because the claims aren't coming in, and they're not necessarily in a healthier state. So when they're in Persona 5 and they don't have all this other chronic conditions going on, we really want them to stay in Persona 5, and we just want to make sure they're compliant with their medication regimen. So that's something critical. Another thing that we know through, again, further analysis is that engagement with a physician matters. It matters a lot. And so for these individuals, we want to, again, understand, do you have a relationship with a physician? Are you seeing the physician? Because if you are, then your utilization, the appropriateness of your utilization is going to be improved. So Persona 6 uncoordinated care, a group of those, it's roughly 20%, are actually pregnant. So if we look at some of the examples that I walked through before, if you're pregnant, you know, obviously we'll want to do something different with you than if you potentially are in a situation where you really have a chronic disease, but it hasn't been properly diagnosed and treated yet. So we want to do something different with you. Also in Persona 6, you know, one of the things that we have identified is we have a group who is opiate seeking, and so that's one of the reasons why their care is showing uncoordinated, because they're kind of all over the map. So we want to keep our eye on those folks. You know, we want to try to get them the care that they need to try to get the opiate issue under control. And the last example is in extreme complex, Persona 9. You know, there we need to start looking at end of life kinds of things. And, you know, are we trying, prior to this approach, you know, are we treating those folks the same as, you know, we're treating potentially uncoordinated care, or someone who is potentially chronic but being managed through meds? Obviously, those are very different scenarios, and so we want to treat them as such. And looking at it this way, cross-cutting the populations, like I mentioned, really gives us the ability to do that. So to recap, our goal here was really find the people and tailor the interventions. You know, we want to know what are those individual scenarios, what are those individual clinical scenarios, and what is the most appropriate intervention for each of those particular situations. So when we look at the who, it's really, you know, tightly segmenting the population so that we can find the opportunities. And in the what, we're optimizing the interventions and making sure that it's most appropriate for that particular group. And then in the when, we're predicting the best time to intervene. You know, we want to get in front of that cost. We want to make sure that we're intervening when it's most effective to intervene. And then, of course, we want to tailor our method of intervention to ensure that we're enhancing that consumer experience. So that's really the presentation, and then we're going to we'll open it up for questions.
A couple of things just to add in real quick. One is regarding the ACG software system, because I know we've referenced that a couple of times. So regarding that software system, that actually is a software system that was originally started in, I believe, about the mid-90s. It was largely put together to do physician profiling, and I think to answer the question of physicians who were receiving reports and complaining that their patients were sicker than other patients and they weren't having their information adjusted for that. So that's really where the product got started. Since then, it has morphed into something considerably more sophisticated than that. We actually use the product a fair bit internally for a variety of things. We do some case mix adjusting based on that. We use it for disease classification. There are some predictors that are part of that. There are a number of other products in the market that do that as well. Honestly, one of the reasons we use it is that it is fairly well accepted in the medical community. largely because it is developed within the medical community. And so while there are other products in the market, that's really one of the reasons we selected it. You can find lots of studies out there that compare it to other products. Some of the differences are terribly minor. Others maybe not quite so much, but we don't. Again, we get no residuals from any sales of the ACG product. We simply have used it internally, and one of the reasons we did select it is because it seems to be a little more well accepted within the community. So that's really one of the reasons we chose to pursue that product and select it as one of the ones that we picked. And we do have some questions coming in, so we're going to have to try to work through this. And I think Cathy may have the first one, and I will read and try to pick up the second one. So forgive us, we're a little slow at this, but we'll do what we can on this one. So
why don't you start on the third one? I actually got through the first two.
Okay.
So in looking at this, I think the first question was around pay for performance, and sharing, you want us to share how the approach translates into a pay for performance value-based purchasing environment. So that is something we've had a lot of discussion on here. I will tell you, we haven't actually done that yet. So it's just discussion at this point. That's in conjunction with what we're doing on an episodic level as well. So we also have that going on where we have an episode strategy with the SIM effort. And so our thoughts there are really to try to tie those things together. We don't want to go off and do something that's different from what the rest of the industry is doing. So what we know, though, is because we have the ability to cross-cut this population and really understand them very uniquely, then we have the ability to roll that into provider incentive programs and really pay for exactly the outcome that we want to have. And hopefully that answers the question, but if not, just feel free to pop up a follow-on question to that.
All right, so where are you?
I think the second question is how often do we run the segmentation analysis? We actually run the clinical persona process every month, and now there are other things going on in the clinical space that are occurring on a daily basis. When they are using the clinical personas, though, they're only run once a month. So there might be a care management process that runs daily. It's picking up the persona information that is run monthly. And we have had some questions initially from our care management staff actually saying, hey, is that frequently enough, or do you need to do that every day? Really what we looked at, we analyzed how often does it change. It really doesn't change. Even though people are flowing in and out of different personas, it's not changing that fast because they have we're putting 12 months of data. We run it with less data if we have to, but ideally we want 12 months of data to really make sure that they're slotting into the right place. If there is not 12 months of data, we won't hold them out. Those individuals, though, will just skew to a healthier persona until more claims information comes in.
So I'm going to pick up a question asking how is successive coordination of care measured? That one actually is
in progress.
That's a layered question, so I'll attempt to answer without consuming the rest of the 12 minutes. So there's a number of ways that we are working to measure that. Some of it is in place, some of it is dictated to us. The state of Ohio actually has some ways that it measures coordination of care. We actually measure it in a variety of ways. We measure it in terms of outcomes as best as we can, and obviously if you've been following that nationally, that tends to be a fairly challenged process in terms of trying to measure that. We measure it just in terms of engagement of the member. We have some challenges just in terms of engageability of the members. That's one where we are really within the last year and a half with some changes within the organization trying to work a lot more with our providers, because honestly the ability of the provider to engage with the member is generally far more successful than the health plan attempting to do that. So we're trying to do that as best we can in conjunction with the provider. So engageability of the member is a measure in terms of just getting them engaged in the process. We have had some, and we continue to do a lot of measuring around what are we seeing in terms of outcomes, in terms of are they engaged. We actually do face-to-faces with our members every 90 days if they're in the high-risk case management program, and that's a state requirement. There are a variety of connection points that we have to have with our members. Those are also all rolled into that. So without getting into a lot of detail, there are some fairly specific things that we are required to do that you could consider to be measures. I don't know that I would necessarily consider those to be success measures. We've just put the persona model in place in a select region in the state of Ohio that started in January, and we actually, so because that started in January, we're just now starting to look at some of the results of that. So our hope is we'll have a whole lot more to talk about within 6 months or so from now in terms of being able to answer some of those questions. So probably not nearly as illustrative as you were hoping for, but we certainly are continuing to work on that. Time to intervene is important. The next question in terms of working with claims in retrospect. Administrative data definitely has challenges. We completely agree with that. We actually don't just have administrative data in our hands. We obviously have data in terms of when somebody is admitted to the hospital. We have that data available to us as well in terms of utilization management data. However, we have done and we continue to have conversations with providers about working with EMR data, but in terms of the personas themselves, data wouldn't necessarily change. Back to Cathy's point, we are actually looking at that on a monthly basis, so we aren't at this point looking at that more frequently than that. We haven't yet had good, strong connections into EMRs to be able to bring that into the fold. That is a conversation we've had with a couple of providers. We're simply not there yet. So yes, this does lag a bit, and that's certainly a consideration that we're continuing to have in terms of trying to figure out how to bring that into the fold, but that's not something we've done yet. We are having conversations with a couple of big collaboratives within the state of Ohio in terms of collecting that data, so we are looking at that. Are you?
So this next one, and we're not 100% sure what's being asked, but the assignment logic when a recipient has ACGs that are both chronic and acute, minor, or major. So if we go to the slide that had the 6 inputs from ACG, those are the inputs that are actually going into the model. And what we're pulling there is just major ADG counts. So if they have minor, we're not actually pulling that in as one of the input variables. The only ACG variable for the ADGs is actually the major count. So hopefully that answers the question. If not, please pop up the follow-on question to that.
There is a chronic condition count that is part of the mix.
Correct.
But then that all feeds into the cluster analysis, and it's going to use statistics to determine where within the cluster that would fall, and then it gets assigned to one of the 9 personas based on that.
Yeah, and I think we had, as Bob mentioned earlier, there was many variables that were tested out prior to landing on the 12 that were actually selected for the input variables. So most likely those were looked at, those other ACG aggregates that were looked at, and the ones that were really a differentiator was the chronic condition count, like Bob said, and the major ADG count. So we did not want to, double up on that because it wouldn't be weighted appropriately.
In terms of clinicians involved, we've actually had a number of clinicians. We actually have some clinicians on the analytics staff itself, and we also have involved clinicians throughout the company in this process. So they have been involved in terms of the development of the personas. In terms of the interventions themselves, that's not the analytic team at all. The intervention process is strictly happening through the care management team, and that is not, the analytic team is not making suggestions for interventions. That would be completely outside of our purview. We may make some, we may from a data perspective make some observations, but in terms of what the actual intervention should be, that's happening within the clinical team.
Yeah, and we really do that hand in hand with the clinical team. We sit with them, and as they are really brainstorming on the interventions, our job is really to make sure that they're using the data appropriately and they really understand what it is that we're telling them through the analysis, and then for them to select the most appropriate intervention. There's a question on CRM software. So we are not yet utilizing CRM software in this. That is obviously a great idea and something we would want to do, but we're just not there yet. What we do have, though, behind the scenes is kind of a manual solution in lieu of having a CRM. So if you do have a CRM, that is obviously preferred. But we have a manual solution, and we work in conjunction with our consumer experience team to really make sure that we're looking at all of those interventions across the board and selecting, and it's very dynamic, so we're selecting the primary intervention, at that particular point in time. So, for example, you might be intervening for some complex chronic condition, but if 3 months from now I wind up pregnant, right? Then the primary intervention point at that point in time is dealing with the pregnancy and not necessarily all of the rest of the issues. Now, that doesn't mean that when the care management team is dealing with the pregnancy that they're not taking all those other things into consideration. They are. It means that as a company, we're not going after a group of people in multiple areas. We're funneling that through, or trying as best as we can to funnel that through one group to enhance that consumer experience.
There's a question about how generalizable we thought these segments are across the entire population beyond Medicaid. We've actually run this in taking data from other states that we've gotten through a variety of ways and pushed it through this. It's been largely Medicaid data. We've found that the model has held true. Our guess is that the bulk of this we believe would hold true. There may be some shifting around if you ran data in this beyond Medicaid. So the answer right now I'm giving you is more gut feel than it is fact. So for an analyst, that's always a bit of a challenge. But from what we've seen so far, I think that we believe certainly the methodology holds true. We believe that the output could change a bit. So it may not be 9. It could shift to a slightly different number if you included commercial and or Medicare in this. The reality is those 9 may largely hold true, but we haven't physically gone through that exercise. So I think the answer is we haven't actually gone through the exercise to give you the answer. We have taken data from other states that looks in fact very different than Ohio, and it has played out to still fit these 9 segments. So, but beyond that, we haven't actually been able to walk you through the process.
So next question is talking about the inputs were claims-based and was clinical EMR data used. It was not, as Bob said, that's something we're working on. That's just because we're not there yet, but I would strongly suggest, utilizing EMR data if you are going to do this, as well as socioeconomic data. We've done a little bit of that, nothing that was ready to actually present today. But socioeconomic data definitely plays into this as well. As you all know, the clinical aspect of this is one thing, especially in the Medicaid population, the realities of life are another. So in terms of tailoring those interventions, taking as much data into consideration as possible is definitely ideal. Although if you're going to do that, then you may need to revisit the input variables because, again, you don't want to double up on anything and things of that nature. So age of the patient and the question about gender and race being were they not important? They're definitely important, but not as an input variable. It didn't play out in the input variables as being important or making a difference, I should say. But it absolutely makes a difference when we're talking about those scenarios that are subsets and the drill down, if you will, of each of the 9 personas. So a perfect example that I will give you is I think every health plan is worried about HEDIS and things along those lines. So we actually have a subset of population that we were going after for postpartum visits and found out that in a particular ethnicity that that particular ethnicity did not allow the mother or the baby to leave the home for, I believe it was, don't quote me on this, I believe it was 90 days. So because of that, that group was never having that follow-up postpartum visit between 21 and 56 days, which is what's recommended. And so when you're talking about tailoring the interventions, you know, home care is obviously something that comes to mind. Is how do you take the care to the member when you know the member is never going to leave the home because, you know, for that particular group, it's not socially acceptable. So that's, you know, it is definitely important when you're talking about tailoring interventions, but not necessarily important when you're talking about selecting your input variables.
And then the last question we see on the screen, and we are right at time, but I will go ahead and tackle this one, is a question regarding outcomes that we've seen with the program. So as we said, we actually just put in place a pilot care transformation program starting in January. We've seen some interesting outcome from this so far, but it just started in January. So we undoubtedly will be sharing some of what we're seeing from this, good or bad, over the next probably roughly 6 months or so in terms of what we're seeing from this. It has been a different method for us internally, and honestly it's been very different for the care managers. In fact, so much so that we've actually had to have care managers go through different training so that they can look at this, because it's a very population-oriented approach to care management. And it's had to be a very different approach for them and a different training process for them. We have, as you can tell, a number of variables in place that we're going to be looking at and monitoring and trying to watch very closely so we can determine what is going to be the impact, and we want to be able to monitor every component of this along the way so we can determine what is working, what isn't working, and then if necessary, what modifications and changes and tweaks do we need to be making so we can make adjustments and then learn from that and hopefully continue to make this process change and better. And based on that, I believe we are right at 2:01.
We would like to take this opportunity to thank our speakers and session participants for joining us today. We will be sending a follow-up feedback form at the conclusion of this event and would love to receive any feedback you wish to share. If you haven't already done so, please be sure to join our LinkedIn group on the web where you can post questions, start discussions, and suggest topics for future events. This now concludes our webinar.